having me. Please let me know if you have any difficulty hearing me. This is quite an honor being part of this webinar with such incredible and accomplished speakers. So Dr. Das, that was I really enjoyed your talk, and it's so many very important points that you raised. So thank you. So this is a bit of a more of a solemn talk. It's a little bit not as optimistic in some senses. So, you know, I think along with all the other speakers today, we probably all are very great supporters of replantation surgery, and we probably take quite a bit of joy in replantation surgery. But I've thought in the past few years exactly where are we, and where did we come from, and where has been. Replantation surgery has been something that's been part of our careers for a long time. So just quickly, I don't have any relevant disclosures to this talk, and a lot of this talk is courtesy of my good friend, Dr. Patrick Reevy, and he and I both have talked a lot about this topic, and have had a couple of instructional course lectures on this topic. So I don't have to tell you the history of replantation surgery. I'm sure that everyone in this webinar is very familiar with it. But I think a couple of things to take away from it is that it's not that long ago that replantation surgery actually became part of hand surgery, and was part of the start of microsurgery. And another thing to take away from it was the great number of people involved with this around the world. You know, there's no one person, I think, that you can say is the father of replantation surgery, but all of these people in some way contributed significantly to replantation surgery, and a lot of them worked in conjunction with each other, but also were contemporaries of each other that may not have interacted with each other at the beginning, but their paths definitely crossed later on. I think of Dr. Chongwei Chen in China versus the American surgeons. You know, a lot of them were developing things at the same time, but not necessarily together. So when we look at the literature for replantation surgery, it's very important to remember that the level of evidence is almost always very, very poor. And that's a significant problem. And like any good investigator, we must know the quality of evidence and know what conclusions we can draw from the evidence. I think something that we do far too often in medicine now is we treat evidence-based medicine as if it is the answer to all of our questions, which of course I believe in evidence-based medicine, but what we don't do a good job of is discrediting bad evidence. You know, it's something like, if there's evidence, we treat all evidence as if it is equal in quality. And that is a very big mistake that we make. So when we look at rates of replantation surgery, it is difficult to know what are exactly the rates. We don't even know the rates of replantation surgery because there's a significant selection bias for replantation. There are very few prospective studies or even databases, and this doesn't allow us to know exactly what is the rate from one location to another. We don't really know the rate of injury. We don't know the rate of patients that aren't even considered for replantation. When we look at outcomes, historically, what we've looked at is survival. And this also has a significant amount of selection bias, because what patients do you include, what patients do you exclude, how does that compare from your institution and or you as a surgeon to your colleagues or other institutions? And also, so the majority of these studies are coming from the large volume centers, which of course they are doing a large portion of the replantations, but they're not doing all the replantations. And we don't even know what percentage of the replantations they're actually doing. And also, when we look at the population studies that have larger numbers, there's very limited clinical data and details about these patients, about these injuries. So even survival rate is actually difficult for us to know. Then this would seem to be the easiest thing to determine. When we look at function, we need to look at total arc of motion. We need to look at sensibility. We need to look at cold intolerance at the very least. But these are very seldom reported. They are irregularly reported, and that's highly problematic. When we look at patient-reported outcome measures, DASH, the Michigan Hand Questionnaire, Quality of Life and estimates, these two are essential for determining outcomes, but they too are irregularly reported. We need to look at function and quality of life. We need to look at replantation versus amputation, but these studies do exist, but they're not true prospective studies. And we cannot effectively control for very important confounding variables, or at least we've done a very poor job of doing so. Briefly looking at previous generations, like I mentioned, replantation surgery was found as beginning not that long ago. And very quickly, the world caught on, and replantation was being done around the world with success rate that rapidly improved. So you can think just less than a decade after replantation surgery was first reported, survival rates were up to 65%, which isn't that different from a lot of survival rates reported now. Also, our future generations of hand surgeons, our mentors and the mentors of our mentors, they were very sophisticated with the technology that they had and the knowledge that they had. They very quickly determined the appropriate indications and contraindications, or at least very similar to the indications and the contraindications that we have now. It's not that different from the indications and the contraindications that we have now. You take a look at this list. This list is more or less agreed upon around the world. There might be some variations, but it's not that different. Another thing to remember, though, and I think one of the things that is different around the world, is the idea of a relative contraindication. In the US, and I'll get to this in a bit, in the US, a relative contraindication is oftentimes treated as as an absolute contraindication. But I think it's really important, and my friend Patrick Reevy, who's a hand surgeon at University of Rochester, was the first one to really make me think of this, and I think he's completely right, is that a relative contraindication is also a relative indication. The difference between whether or not you think of it as a relative contraindication or as a relative indication is your starting point. If your starting point is not doing something, then I think you look at it as a relative contraindication. You're looking for a reason to not doing it. If your starting point is doing something, then you are looking for indications to do it. And then that indication may be a relative indication, not an absolute indication. And I think that is maybe a fundamental difference between a lot of replantation surgeons or surgeons that do replantation, is how do they treat those relative contraindications? Are they starting from not doing it, or are they starting from doing it? Now, even when you take a look at the contraindications, and this is from your starting point, crush and avulsion injuries are, of course, not favorable, but they're not absolute contraindications. For example, if you take a look at this meta-analysis, the survival rate is not a insignificant survival rate. Now, to be fair, this is survival rate, this is not function. And when we take a look at single-digit zone 2, which at least in the US is treated very strongly as a contraindication, the sensory recovery for single-digit replants is also not insignificant from previous studies. 2-point discrimination of a little bit less than 10 for a clean laceration. With this study, when they looked at sensory recovery, and they looked at end-to-end coaptation versus replantation, once again, it's not that different. So a sensory recovery in a replantation for a single digit is not a negligible recovery. This study is from Six People's Hospital out of Shanghai, which is, as we know, one of the epicenters of the development of replantation surgery. But this study, I found a very interesting study. You should read this study because it's quite detailed. But what I took away from this study is that a single digit replant can be much more functional than a revision amputation. So the relative contraindication of a single digit zone 2, this study shows that that is a much more nuanced relative contraindication. This study, I'll spare you the exact details, but they were found is that functional outcomes were different for different digits. For instance, thumb, index finger, and middle finger showed more functional outcome for single digit replant versus the small and the ring finger. Now, whether that is true for everyone, I don't know, but what it does show me is that single digit replant is a nuanced indication or contraindication. Also, we know that there are competing views about single digits. This is two very esteemed surgeons writing about single digits and specifically the index finger, one arguing against the index finger and the other one arguing for the index finger. When we take a look at trends in America, this is also an article by my friend Patrick Reevy. He did excellent work in looking at what is going on in the US with the emergency room visits for finger amputations, which are staying relatively the same. Now, this data is now 10 years old, and it would be interesting to redo it, but I anticipate that the results would show the same trends. But when we take a look at the number of replants during that same time, it's going down. So it's not as if amputations are not occurring. Amputations are occurring, probably at very comparable rates, but the number of replants are going down. Also, the number of replants at various hospitals shows that there is a significant number of hospitals that do very small number of replants. One replant a year at over 300 hospitals. Now you think, would those patients be best served at a high volume center? The answer is almost definitely so. When you look at where the replants are being done, and this is a systematic review of replantation, you see that a significant preponderance of the literature is coming from East Asia. The rest of the world is at least not publishing on this and most likely not doing nearly as much as East Asia. This is a graph that we put together as well. The red line are papers that originate from North America. The blue line, blue dots, are papers that originate from East Asia. The x-axis are the years that they were published. As you can see, as we go from the 1985 to now, the survival rate reported in the papers from North America for replantation, so success rate here is defined as survival rate, is not a positive slope. It is decreasing. Of course, there's a line of best fit, so there's variability. It's not a direct linear relationship. But when you take a look at the papers from East Asia, their survival rate remains very high. If anything, it might actually be increasing. Now, this doesn't prove that there's a problem, doesn't prove that there's a problem in survival rate or a difference in survival rate, but at least in the literature that's reported, there's a significant difference in survival rate, and one that is not optimistic for North America. So what is going on? In North America, we are doing fewer replants. And it also seems that we are doing those replants less well. This is not good. If you're going to do something less often and you're going to do something less well, then that will only encourage you to do it less often in the future, which will only further decrease your outcomes. This raises a lot of questions about what is the future for replantation surgery around the world, but specifically what is the future of replantation surgery in the US? But also, what should the future be for replantation surgery? The reason why I bring that up is this patient is a patient of ours. It was a work-related injury, failed replant, and then failed toe transfers. Now, they were fortunately not by me, So now he is stuck with this hand that has what looks to be a mushroom on it, but it's a groin flap that was used to close the site of the failed toe transfers. He is in a terrible position. He can't use this hand, and it is aesthetically very ugly. So for these patients, the field of prosthetics are becoming ever more possibilities for him. So this procedure is called the starfish procedure, and was developed by my colleagues at OrthoCarolinas in Charlotte, North Carolina, Brian Loeffler and Glenn Gaston. But what this essentially is allows for myoelectric functioning of a partial hand prosthetic. It's not targeted muscle reinnervation, but it's moving the interossei, the dorsal interossei, superficially so that they can be used as strong EMG signals, surface EMG signals for a partial hand prosthetic. This is the patient. The first day a myoelectric prosthetic was applied to him. He has never been trained on a myoelectric prosthetic before. And as you know, for many of you that work with myoelectric prosthetics, it takes a significant amount of exercise and working with therapy to learn how to use it. So this patient is already exhibiting individual finger control. He has good finger control of the index finger, and you'll see he has the ring finger, but this is very exciting. So this raises the question, what role should replantation surgery play in the future if we will be able to get excellent results with partial hand prosthetics? So in summary, going forward, we absolutely need improved research. We need research that focuses on function. We need research that is large databases. We need research that tries to limit the heterogeneity of the patient population and the mechanisms as much as possible. We need large numbers. We need standardized patient-reported outcome measures. We need to create centers and very much support centers of excellence for replantation, so that those centers can be funneled to replantation, so that they have the critical mass of the high volume, and also that people can come there to train. So the knowledge is focused, and it allows people to train there and then take that knowledge elsewhere. And then finally, also, we have to focus on function with these patients, not survival. Survival with replantation is woefully inadequate. And then finally, the further discussion of replantation versus reconstruction, and specifically prosthetic reconstruction, and what role this plays going forward, and how this may shape how we do replantations and when we do replantations. But all right, thank you very much